Can everyone see my slides?
Mhm.
Very good. So today, just briefly, I want to touch on a deep subject, how to predict, prevent, and treat radiation retinopathy. As you know, I'm from New York. What is radiation retinopathy? Well, it is a progressive occlusive vasculopathy that was described by Archer and Gardner many years ago. It's characterized by vascular endothelial and parasite cell loss. It starts at treatment, though it may not be visible at the time of treatment, but the clock starts ticking once we treat patients with a certain level of radiation that will later become clinically evident. It is dose dependent. There is a subthreshold disease where we may never see the changes unless we look at them very closely, possibly with OCT or other forms of imaging. There's suprathreshold treatment that becomes clinically evident with resultant severe vision loss, particularly in posterior cases. And the severity is predictable. It's based on dose, dose rate, and dose to normal ocular structures that can be calculated. This is the vasculopathy pathogenesis. As I said, we start with vascular cell loss, which leads to vascular permeability. The primary sign is edema, but also you can see shunting of vessels and neovascularization that contributes to edema. And the loss of vision is at first related to edema, but later to an occlusive vasculopathy. This is what we commonly see. This is a choroidal melanoma, status post-plaque. We see cotton wool spots. We see intraretinal hemorrhages. We may see edema. And this is relatively early in the phase of the evolution of the disease. We did a study showing that posterior tumors were more likely to develop radiation maculopathy. And as you see that as you go farther posterior, the dose to the macula increases, and that is the primary risk factor. The other thing you see by looking at this graph is that it increases generally over the first 5 years, and then it starts to level off. This is an interesting graph that was recently created, and this shows that different forms of radiation will deliver different amounts of radiation to different structures. For example, on the left of the graph, you see that there's a great difference between the amount of radiation given to the sclera and therefore the subjacent choroid and retina when you compare ruthenium versus palladium, or you could easily just swap out iodine 125 as well, in treatment of tumors that are 5 or 7 millimeters tall. The dose to a 7 millimeter tall tumor using ruthenium can reach as high as 1800 gray. And that is why we often see clinically, for those of us who use ruthenium, chorioretinal atrophy in the targeted zone after treatment of taller tumors. When you get towards the apex of the graph, you see that it's normative because they all come together because they're given, in this case, the same apical dose. In some studies that we performed, we found that in general, and this is patient specific, but in general, if patients receive less than 15 gray to their macula, they're less likely to develop radiation retinopathy. That would be the subthreshold group. When you give between 15 and 25 gray, you have a small risk. 25 to 50 gray, moderate risk, and almost everyone who receives over 50 gray to the fovea, it will develop radiation retinopathy. Therefore, we use that group as a high-risk group when we recently published our comparison of early treatment of radiation retinopathy versus historical controls of untreated patients. That appeared in Ophthalmology Retina in January. So how do you prevent loss of vision or loss of eye due to radiation vasculopathy? Well, we all know that uveal melanoma and ischemic retina produce VEGF. We accept that radiation retinopathy starts at the time of plaque therapy. So if we stratify the patients to risk, we know which patients we need to treat. In my experience, early, frequent, and persistent suppressive anti-VEGF therapy will preserve vision. What I mean by frequent is typically every 4 to 6 weeks for most patients, but that's not enough. We'll go into that in more detail in a minute. Persistent treatment will also suppress iris neovascularization and thus secondary glaucoma. So most of us who treat choroidal melanomas know that anti-VEGF therapy will restore macular anatomy. It'll decrease retinal edema. It will cause resolution of retinal hemorrhages or cotton wool spots if they're allowed to form in the first place. They'll suppress neovascularization, and they'll preserve visual acuity. I believe it will also delay capillary dropout. This is a couple of clinical cases of before on the top and 8 months after periodic intravitreal anti-VEGF therapy. You'll see that the cotton wool spots and hemorrhage have largely disappeared, and I believe they can be used as a method to see whether or not your treatment is working. You should expect over time that the hemorrhages and the cotton wool spots disappear with periodic suppression. Here's another example of macular edema before anti-VEGF therapy at 2050, and 1 year later, a patient has regressed macular edema and 20/20 vision. Here's a subfoveal tumor treated with anti